Good evening, everyone. Today, Parth, Preeti, and I would be discussing on various problems we face during vitrectomy and various maneuvers we do to overcome it. I'll be talking on problems we face during visualization. So, what happens when the view is bad? Accidents happen only when the view is bad, right? So, prepare to avoid bad weather. How do you prepare to avoid bad weather during vitrectomy? So, preoperatively, you will have to assess the patient thoroughly with slit lamp examination and carefully assess certain parameters that will help in planning the surgery. So, first, when you look at cornea, you'll have to look at presence of corneal scars, opacity, blood staining of cornea, especially in trauma cases, and also look for the LASIK flap, RK marks, so that you know if the corneal opacity is too much or if the blood staining of the cornea is present, you may have to combine it with PK and VR surgery. So when you look at anterior chamber details, you look at presence of hyphema or fibrin in the AC, as in trauma cases, and then you plan a AC wash accordingly. Then you look at the pupil. If the size is small, then you'll have to keep pupillary expanders, iris hooks handy during surgery. If you take a lens status, you have to see if the patient is phakic or pseudophakic. If the patient is phakic, then you'll have to look for the grade of cataract. If the patient has a dense cataract, then you may have to combine phacoemulsification and IOL along with VR surgery. Or sometimes we can even plan lensectomy in a very complex cases, which includes PVR and pars plana membranes, where you'll have to do a lensectomy. So if the patient is pseudophakic, then you look at the type of IOL, whether it is AC IOL, iris claw fixated IOL, posterior chamber IOL, if it's in the bag, if it's in the sulcus, and so on and so forth. And also look for the position of IOL if it's well centered, subluxated, or dislocated. Then, in case of subluxation, you may have to reposition the IOL during surgery, and if it's dislocated, sometimes IOL explantation is also an option. So, status of posterior capsule, you have to look whether PC is intact or not. This plays an important role when you do a FG and also you want to fill the eye with a tamponade. And also look for the presence of posterior capsular opacification. So, in such cases, you may have to do a PC opening for better visualization. So there are certain prerequisites prior to starting a case. First comes priming the machine, then check whether vitrectomy cutter is working, cautery is working or not, check whether the illumination of the light pipe is adequate, and then do a proper draping in order to avoid fogging intraoperatively and maintain good ergonomics. So focusing is important to have a clear visualization throughout the procedure. The first step we do once we place biome and recite in position would be par focusing. So how do you do par focusing is that you put the patient and then like you focus with high mag, focus on the disc at full zoom, and then do a fine focusing on the disc. And then once the disc is in proper focus, then whenever you zoom in or zoom out throughout the surgery, your focus does not change. As you can see from the video, first we had focused on the disc at high mag, and then you can see that during the entire surgical process, wherever you keep the light pipe or cutter, the view doesn't change at all, even if you zoom in and zoom out multiple times. So the most common problem we encounter is fogging. What do we do to avoid fogging? You have to do a proper draping. So this video shows that first you place a initial drape, and then you place a tegaderm. How do we place tegaderm is that one assistant can hold either side of the lid with a cotton bud, and then you make sure that the tegaderm sticks on both sides of the lid and there's no gap in between. And once that is placed, you place a eye drape on top of it, and then you cut accordingly. Make sure you don't make too large a cut nasally. So, in spite of all this, if there is still fogging, then you'll have to check the distance between your objective lens and the cornea. Sometimes, if it is too close to the cornea, then that can cause fogging. And check the drape. If the cut is on the nasal side, if it's too much, then you can place a tape over it, and you can make the assistant to place a wet cotton bud over the nasal bridge, or even they can place a muscle hook at times. And saline soaked gauze can be placed, and also check if the heater is on, you turn off the heater. So there have been various studies where they have looked at various methods like adopted to prevent condensation of objective lens during vitrectomy. So, a study by Lee et al. They've looked at warming of the objective lens at 1 minute and 5 minute interval and compared it with the condensation times at various distances from the cornea, like 1 minute, 1 mm, 3 mm, and 5 mm. And they said that it is statistically significant that warming the objective lens actually helps in preventing fogging. They have also looked at coating the surface of the cornea with viscoelastic substance and compared it with similar condensation times. And they said that optimal distance would be 5 mm from of the objective lens from the cornea. And this is another interesting thing which they have used in a study by Sami et al., where they've used urinary catheter. They have cut the one edge of the catheter tangentially and then placed it on the nasal side near the medial canthus, and they have stuck the urinary catheter there and connected it to a wall suction pump. So what it does is it generates a vacuum so that it takes all the vapor from the medial side into the suction pump. So what are the problems related to media? The first would be corneal haze. Why does this occur? When there is IOP fluctuation during vitrectomy, longer duration of surgery, and during combined procedures, diabetic patients with poor epithelial function, iatrogenic damage to corneal epithelium while cutting the drape. How to prevent it? Frequent installation of saline over the cornea, but you'll have to be careful while doing this because this itself can decrease the vapor pressure of the cornea and can cause fogging of the lens. Best would be to coat the surface of the cornea with viscoelastics. But in spite of all this, if the haze is worsening and visualization is compromised, then you'll have to do a corneal epithelial debridement. So in this video, you can clearly see that it's a RD case and the details are compromised. You are not able to see anything clearly. At this stage, if you continue to do the surgery, you may end up with complication. So we do a epithelial debridement. One thing you have to keep in mind during epithelial debridement is that you have to start from the periphery out to in, not the other way around. Keep the margins of the epithelium smooth and always preserve a peripheral rim of cornea because the wing cells migrate from the limbus towards the cornea and that will help in reproliferation of the epithelium. So we always leave a peripheral 1 to 2 mm rim. Here in this video, you can clearly see after epithelial debridement, view has become drastically better. And now you can go ahead with the surgery. So hazy view due to contents in the anterior chamber like hyphema or fibrin. You perform an AC wash with saline or viscoelastic and clear the AC and then you go ahead with surgery. So difficulty in visualization due to small pupil, but first before shifting the patient inside, you see whether adequate dilatation drops has been applied and also see if there is presence of posterior synechiae, then you do synechiolisis. Applying phenylephrine drops over the cornea, intracameral injection of adrenaline, pupillary stretching, or in this case, like as shown in the video, you can place iris hooks to enlarge the pupil. So if there is a cataractous lens, as I told before, you can combine with phacoemulsification or sometimes you can plan lensectomy also. In pseudophakic patients, if the lens is subluxated or dislocated, repositioning or IOL explantation should be considered. In case of posterior capsular opacification, you make a PC opening, either with a cutter or if the membrane is too thick, then you'll have to use scissor to open the PC. Make sure the opening is not too large or too small. It should just be of adequate size. And sometimes there can be presence of membrane over the IOL or presence of pigments over the IOL. In such cases, you'll have to remove those membranes as well. So management of fogging during FG. First of all, one thing we have to remember before FG, we have to make sure that the laser machine is kept ready and it is in working condition. Also check for any bleeders. If there are any bleeders, cauterize it. And then you start FG. So during FG, there are various causes of fogging. If it's a phakic patient, there can be drying of the air on the posterior capsule of the lens. So that can cause fogging. And if in the case of pseudophakic patients, and especially if the PC is compromised, then you can see that there is condensation on the posterior surface of the IOL. And whereas in aphakic patients, it is mainly because a pupil automatically constricts during FG, and there can also be presence of Descemet's fold. So that can cause fogging during FG. So in such cases, in aphakic patients, you can coat the endothelium with viscoelastics, and also sometimes if the posterior capsule is compromised, then air can enter into the anterior chamber. It can escape and enter into the anterior chamber, and that can cause fogging. So in such cases, you inject viscoelastic, push the air behind, and then you perform the surgery. And if there is condensation on the posterior surface of the IOL, so you can, if majority of the surgery is over, if only a very small step is left, then you can use flute needle to just brush the surface of the IOL, posterior surface. Whereas the other option is that you can coat the surface of the IOL with viscoelastic substance that will form a filmy condensation on the surface of the IOL. There are other aids which can improve visualization. I'm not going into details, but these are the things that can help you during visualization, like IVTA to stain the vitreous and brilliant blue to stain the ILM. This is a case of myopic tractional maculopathy, where we can show the IVTA assisted removal of the cortical vitreous. Like when you stain with ILM, you can see that there is patchy staining of ILM. And then we remove the cortical vitreous, IVTA stained cortical vitreous. So there are other viewing system like Lander's contact lens and non-contact macular lens for fine macular surgeries. So this video shows first thing is Lander's contact lens, everything done in the same patient. So when you use Lander's contact lens, you can see that field of view is very small. It is only about 30 degrees. You can only see the macula. You cannot go beyond the arcades when you are using Lander's lens. Whereas when you use a non-contact macular lens, the field of view is about 60 degrees, and you can comfortably peel the membrane which are outside the arcades also. And this is a wide angle viewing system which we normally use, just to show the difference of each. One disadvantage of using the contact lens is that there can be frequent decentration, so somebody has to center it often. And then one more thing is that as the field of view is very small, you will not know where the instruments are going inside. So first, before trying to focus with contact lens, keep the microscope light on, focus the instrument through the contact lens, and then you start focusing so that you can avoid inadvertent damage to the retina. So in conclusion, the presence of intraoperative media haze, meticulous evaluation of cause of haze, and patient management of the same can result in better surgical outcomes. Proper preoperative assessment of the eye for the possible causes of poor visualization and small pupil can help in better planning of surgery. These are my acknowledgements. Thank you.
We'll take the discussion now, and then we'll go to the next. Please go ahead, sir.
Can you go to the first slides? Next one. Yeah, next. Okay, I think before you do anything, first you make sure that your own spectacles are clean. Okay, smudge on your glasses can also have, especially when you do ILM peeling, every little bit of haze gets added up. So the last thing we do is to clean our glasses properly. So make sure that before you start surgery, your lenses are clear. Especially if those who are wearing glasses while operating. Because there are many who remove glasses and incorporate the power in the microscope adjustment so that they don't need to wear glasses, which is fine. But if you have a little bit of cylinder or you're a presbyope like me, where you need to have near vision outside the microscope also active, you continue to retain the glasses on when you're operating, okay? The second thing is, when you said phakic, it's important to realize it's not the grade of cataract, it's a very loose term. It's the location of the lens opacity which is more important. Nuclear sclerosis, even 3+, you can actually do a very good vitrectomy when you're inside the eye with light pipe, as long as there are no posterior capsular changes and cortical opacities. But one thin posterior subcapsular opacity is enough to cause maximum interference with your surgery, although the rest of the nucleus is clear. So what is important is the location of the opacity. So that's where it's so important that when you advise surgery, you must put the patient back on the slit lamp, examine the lens carefully to see whether you should plan for a combined cataract surgery or not. It's important to understand that you can always plan for cataract surgery. You need not do it. If on the table you are able to manage, you don't have to touch the cataract, it is fine. But if you don't plan in advance, you miss an opportunity to give them an intraocular lens at the same time. These days, we very rarely do a pure lensectomy, except of course, there are select cases where you should do when you want to remove all capsular remnants because of severe PVR, etc., etc. In most cases of PVR with RD with cataract or diabetics with cataract, you tend to combine with a phaco rather than a lensectomy. And with or without IOL, you can retain the PC, put an IOL later on, but at least you do a phaco, right? So it's important that you must calculate the IOL power and keep it with you. So in case you're able to put an IOL at the same time, go ahead and do it, okay? So if there's a RD, you can always argue that you cannot put an IOL at the same time because you can't calculate the IOL power. But yes, in a few cases where you are sure about the pre-RD refractive status of the eye, like somebody says he's using the same glass power in both eyes, and they develop RD in one eye, you can always use the other eye refraction for an actual length or putting in the IOL, okay? Some clues to tell you so that you avoid one more surgery, basically, for that. About corneal clarity, you're talking about, can you go to the next slide? I think long before you say priming machine and all that, the first thing I would do is that you are comfortable with the foot switch on both sides. I've seen a lot of people sitting and saying, asking the nurse, which is the switch for the cautery, which is the switch for the cautery. So that is something you are not supposed to be doing. You should know what the switch is doing in every OT, so that you don't have to waste time on asking the nurse which is the switch for the cautery. Okay, so being comfortable with both the foot switches for the microscope and for the cutter. Okay, check the illumination, proper draping, all right. Now draping, there are umpteen number of ways of doing draping. Despite all that, we still keep getting fogging. It's not a problem which is unique to our country, it's there everywhere. But in our country, probably with our facial configurations with more prominent nose and a deep set eyes, the fogging is even more a problem because the drape gets lifted up very easily. Okay, yes, we keep struggling, we keep trying all over the things. The last article which you showed about the urinary catheter, it need not be urinary catheter, any catheter should work as long as you're able to suck the gas away. And we have a lot of sterile catheters available in the OT. Maybe we should try, in one of the cases, just stick it around the nose and try to attach it to a suction and see what happens. So there's a good technique which you can definitely adopt in really difficult problems where you have an issue. What we do is initially when you bring the lens in, it almost always gets fogged. Okay, but you take it a little away from the cornea, it gets defogged. Then gradually bring it down. The lens also learns. It's not an active learning, it's just a question of adapting to the fog. After all, if you take an indirect 20 diopter lens from the general ward to one of the rooms on the sides, 31, 32, etc., the minute you open the box, it gets fogged because it's been in a cold environment and you bring it to a warm environment, it gets fogged. But you leave it for some time, it gets defogged. So like that, very often the lens tends to adapt to the existing humidity and temperature, and it doesn't fog as easily as it was doing initially. But still it can get fogged when you go too close to the cornea because the humidity is highest there, not a little away from the cornea. So you can keep on going back and forth and doing your surgery rather than trying to worry about the fogging. But yes, if it's still a problem, yes, you try to do something like, even in the worst cases, I even removed the entire drape and stuck again the tegaderm to make sure it's not fogging. All right, can we go back to the good next slide? Okay, par focusing is fine. Next one. Okay, next one. Okay, next one. Again, can you go back? Now this is, to me, a compromise because there is always a small chance that you can contaminate your hands because you're trying to stick the entire drape onto the eyeball around the eye, or you may end up sticking it so eccentrically that, like what you did. Can you continue the video? See, you have to lift it up and put it back. Sometimes it can be so eccentric that it can actually potentially go from a unsterile sticking surface to a sterile sticking surface. So what I would suggest we should do routinely is two people, the nurse and the assistant or the surgeon, should do the draping. They should open up the drape and stick it under direct visualization so that the circle goes exactly around the eye and not too eccentrically. When it goes too eccentrically, and if a large part of the blue drape is across the bridge of the nose, that area gets lifted up very easily because it is stiff. It is not like the plastic drape. And whatever you do, the plastic drape gets lifted up because a thick plastic is keeping it lifted up. So the circle should be totally around the eye and onto that side of the bridge of the nose, not on this side of the bridge of the nose. Okay? So that's why I said open it up and stick it. Don't stick it and open it. Okay? And using the tegaderm, whatever you're comfortable with, you can do. These days, what I was doing here is cutting it into two halves and sticking it directly along the margin, not over the eyeball. That seems to hold it better than trying to stick it across the eyeball, because anyway, the plastic drape which you're opening is covering the lid margins. So the tegaderm is being used mainly to stick down the blue drapes margins so that they won't get lifted up. Okay. Anyway, you can, whatever you're comfortable with, you can do. Next one. Okay, next one. Okay. Here I would like to say that with experience, you find that the number of cases where you remove the carnal epithelium become lesser and lesser. I still remember that maybe in 1990s, when I started my vitrectomy surgery, I was ending up removing the epithelium in every case almost of retinal detachments and diabetic patients. The worst thing that happens is post-operatively, the epithelium doesn't heal easily in diabetics. Then you end up, those days we were not using bandage contact lens. You kept on bandaging the eye for 2 days, 3 days, and trying to get the epithelium to heal. So don't underestimate the fact that the epithelium may not heal easily in these patients, and especially when you're trying to use steroids and that, you're always concerned that the epithelium may not heal properly, can actually develop infiltrative keratitis. So try not to remove the epithelium easily. One way of avoiding it is in steps like what you have shown of doing vitrectomy. You don't need that crisp visualization. With that haze, I can still operate. You're only removing the vitreous gel. When you remove the membranes, if you're having difficulty, you can roll a wet cotton bud across the cornea. It deturgesses it. It removes enough fluid from the cornea to permit the surgery. It again becomes edematous. Again, you do it again. So you can avoid removing the epithelium by doing that step. And only when I have to do ILM peeling, I end up removing the epithelium if I have to. But in most cases, I avoid removing it. Okay? All right. And trying to hydrate too frequently also produces corneal edema, because the saline is probably not the best hydrating solution, wetting solution for the cornea. That can actually produce hydration as well. So while if you put viscoelastic, sometimes it is good, but the methyl cellulose also tends to stick to the cornea and produces the kind of precipitation which itself can interfere with visualization. Ideally is to use sodium hyaluronic acid as a wetting agent, but it's very expensive and we can't afford to use it in every case. We are not using it. We are using methyl cellulose, but methyl cellulose is not the best wetting agent, but unfortunately we are forced to use it. Okay, but if you can afford it, use sodium hyaluronic. That's pretty good. Next one. Yeah, antichamber is fine. We already mentioned it. Fibrin. Yeah, the best way is actually intracameral, not phenylephrine, but intracameral adrenaline. Okay, we don't use intracameral phenylephrine. So adrenaline, 1 in 1,000, you dilute it 10 times, it becomes 1 in 10,000. So 1 in 10,000 adrenaline, if you inject, it will dilate beautifully. There's no problem at all. Okay. And in fact, in many cases, because we are using tropicamide routinely for dilation, if on the table you use T plus 1 drop, after having put tropicamide 4 or 5 times, just that 1 drop can make all the difference. People dilate dramatically. You don't actually need a intracameral adrenaline. And 1 drop of tropicamide plus doesn't cause too much of blood pressure rise, etc., etc. So I usually tend to tell the anesthetist, occlude the punctum and put a drop of T plus after having put enough number of tropicamide drops. That should take care of it. All right, next one. If still it happens, of course, you can use the hooks and all that. This is okay. Next one. Okay, next one. Next. Next. Okay, I think that's it. Those are the points that I have got to make.